So today I'm talking about telehealth activity reporting and funding, a Queensland perspective. I apologise in advance for the dryness of this topic, especially following Shane's YouTube clip. I don't have any memes and I don't have any YouTube, but hopefully I have all accurate information. That's what you all call me for anyway, isn't it? Yeah, so, all right, let's get started then. Reporting and funding telehealth activity in 2016-17, I'm going to go through 5 elements: non-admitted patient telehealth service events, admitted patient telehealth events, emergency department telehealth consultations, store and forward assessments, and the KPI for this financial year. I haven't mentioned mental health activity in here, but there is also mental health reporting and funding available. Okay, a non-admitted patient telehealth service event. We use the Australian Institute of Health and Welfare's definition for a service event, and that's an interaction between one or more healthcare provider with one non-admitted patient, and it must contain therapeutic or clinical content and result in a dated entry in the patient's medical record. Now, if you want to capture non-admitted or outpatient telehealth activity data, you must meet this definition. And then when we capture that telehealth service event, we just add video conferencing into the end of it essentially. So it's that same service event and the delivery mode is via video conference. In Queensland, we have a localisation where we enable the reporting of a telehealth service event at the recipient and the provider end. This is unique to Queensland. We capture telehealth service events in patient administration systems that we use to report or to book outpatient appointments. So some sites use Hibiscus Appointment Scheduler. We've also got ESM. We've also got ASIM. I think that OSM has been replaced by ESM. So there are a range of different systems across the state. I think Taurus uses best practice. The activity is reported via the Queensland Health Statistical Collection, the monthly activity collection, and this collects aggregated counts of non-admitted patient telehealth service events. The MAC has 4 forms related specifically to telehealth. We've got one for one-on-one provider-end telehealth consultations or service events, and the same for the recipient. And then we have a form for group telehealth events and group provider and telehealth group sessions. And this Excel here is a link to the MAC form. I'm not going to go to it. All it is showing an Excel spreadsheet of the monthly activity collection form. If you want to see the spreadsheet, come and see me. We've got a trade display, the telehealth support unit, and I'll show you the spreadsheet. Funding. Now this is the interesting part for a lot of people because without the funding, the services aren't supported. So a lot of people ask me about telehealth funding. For non-admitted patients, we can fund private non-admitted patient telehealth services with the MBS items. There are 11 for the specialist end and there are 23 for the patient end. There is a minimum distance requirement of 15 kilometres, but that excludes residential aged care and some other sites. And the billing requirements for the MBS items must be met. The Queensland activity-based funding model has a localisation which pays both the provider and the recipient end of a telehealth consult, and we pay by the Tier 2 clinic type. The Healthcare Purchasing Initiative is an additional purchasing lever that sits on top of the Queensland activity-based funding model, and that pays $200 for additional non-admitted public telehealth service events above actual volumes from last year. So any activity above what was reported last year, if that activity is public, and the Tier 2 clinic type reported has a non-zero price weight attached to it, then you're allocated the $200. The Independent Hospital Pricing Authority set the Tier 2 classes And they introduced 2 new ones last year, and they were to capture the patient location for both medical officer and other health professionals. Queensland has not implemented these 2 new IPA Tier 2 classes, and we continue to capture and report recipient and telehealth activity by the clinic type that best represents that service. And we also fund based on what clinic type is reported. The Queensland model is a lot more generous than the national model, and the pricing is by whatever Tier 2 clinic is reported. Admitted patients. Admitted patient session is defined as the transmission and receipt of real-time audio and visual information via video conference between participating sites. So we have an admitted patient telehealth event. You can think of it in terms of a ward round. So say in a ward you've got 10 beds. Each of those patients in those beds is participating in an admitted patient ward round for telehealth. So the video conferencing system would be wheeled to the first bed, and then to the second bed, and then to the third bed, etc. So each bed or each patient represents an event, and those 10 beds that are seen within that one video conference connection represents a session. So in reporting and capturing admitted patient telehealth activity data, we capture events and we capture the whole session. And we capture that activity data on Hibiscus in a telehealth inpatient details screen, and you can get to it via the admitted patient module. The activity is reported out of the Queensland Health Statistical Collection, the Queensland Hospital Admitted Patient Data Collection. Now, in order to get onto that collection, you must have that activity reported in Hibiscus, the hospital-based corporate information system. If it's not in Hibiscus, then it doesn't get captured in the QPADC, the Queensland Hospital Admitted Patient Data Collection. This is Hibiscus. I don't know if many of you have seen it before. It looks very old-fashioned. But the telehealth inpatient details screen enables us to capture admitted patient activity data from the point of view of the recipient, and they have the patient, they have the patient's medical record, the telehealth inpatient detail entry is related back to that admitted patient, and that's all at the recipient end. So the provider end doesn't actually capture any data. The recipient end identifies who the provider was. So it's very important that our recipient ends are reporting the data accurately, because if the activity data is not in the telehealth inpatient details screen, it doesn't get picked up in the QPADC and it won't get funded. The healthcare purchasing intention for this year gives a payment of $200 for provider ends of admitted patient telehealth service events. We're excluding allied health and nursing, so we're only including those service events those telehealth events that are delivered by a medical officer. We also exclude where the recipient and the provider end are the same. Emergency. Emergency telehealth activity data can be captured in EDIS, the Emergency Department Information System, and we also have an equivalent one for rural sites. There are a number of local patient administration systems used to capture emergency activity data. I've even heard of spreadsheets being used. We have TEMSU as well. TEMSU are out in the foyer as a trade display. And they are an emergency management support service. So we do also get some activity data through TEMSU, and that enables us to capture those sites that don't have EDIS or rural EDIS. We're able to gather that information via TEMSU. This year we're providing, the healthcare purchasing intention is providing $100 to provider ends only. For those emergency department specialist consultations. Once again, we're excluding allied health and nursing service events, and those events where the provider and the recipient facility are the same. Store and forward. Store and forward is brand new, and the scope for store and forward at the moment isn't really meeting the business need, but it is what it is. At the moment, we're defining store and forward as the acquisition and storing of an image for clinical purposes that is then forwarded or retrieved by another clinician at another site for clinical assessment. At the moment, the capture of store and forward activity is done at a local level. It's captured in local data collection systems. We have one requirement in whatever system you use. You must be able to ensure that the images are transmitted and stored securely in a repository that enables that image and associated clinical content to be retained and retrieved. The reporting of the store and forward assessments is done via the monthly activity collection, and it's only captured by the provider end. So only the sites that are providing the assessment may report store and forward activity. This is a section of the monthly activity collection form, and on the form we can see that there are only 4 clinic types that are enabled us to, where we can capture store and forward assessments, and you can only capture and report dermatology, ophthalmology, ENT and wound management. Now we know a lot more services are using store and forward, and this is not capturing those. I listened to a presentation this morning on podiatry, and that wouldn't necessarily be captured. So there's a lot of room there's a lot of room in the reporting to be done for store and forward, and we also need to look at the funding model again for next year and see, is it really meeting our business requirements, and what we need to do to change that. Store and forward assessments receive $100 for the provider ends, and as I said before, it's only those 4 clinics: derm, ENT, ophthalmology and wound management. The store and forward assessment, in order to qualify for the payment, cannot occur during a face-to-face service event or a telehealth service event. So if you're having a telehealth service event and during that service event the clinician at the providing end pulls up a scan or something and provides an assessment of that scan during the telehealth service event, then that's counted as a service event and not a store and forward assessment, because it's happening within that telehealth service event. We've excluded evaluation of images, as I said, for the in-scope telehealth or face-to-face events, and images for admitted patients. So the store and forward payment's only for outpatients, and we've also excluded assessments of x-rays and radiology reports. Finally, the key performance indicator. This year we've got a 20% target and it's for all HHSs, all hospital and health services. It's related to non-admitted patient activity data only, and it's requiring a 20% increase on the baseline on the previous financial year. On the trade display outside I have a document which is the spec for the KPI. It details what the baseline is and what the target is for this year. The source of the data is the monthly activity collection. So it really gets down to, if you want to meet your KPI, if you want to ensure that your HHS is getting adequate funding or appropriate funding for the telehealth services you're providing, the activity needs to be reported. In closing, I think that I'll say that our funding model is great in that we capture both the recipient and the providing end of non-admitted patient telehealth services. We're providing payments for store and forward, emergency, admitted service events. I don't know of any other jurisdiction that's doing that. So we've advanced quite a lot in the last year or so in terms of funding and reporting telehealth, but we have so much more to go. We really need to continue to look at the business and not try and fit what's happening into the existing funding model. If it doesn't fit, let's not force it to fit. Let's think about it and build a business model and a proposal to expand the funding model and to expand the reporting system, so that we really get an idea of what telehealth is occurring, what that actually looks like, and make sure that it's adequately and appropriately funded in the future. These are my contact details. call me or contact me anytime on email or phone, and I'll be at the trade display through the day as well, tomorrow as well. So, yep, happy to talk. Thank you. Oh, questions? I should have asked questions.
Just following on from Sheila's talk, it looks like, specialist endocrinologist into the home is supported by what you just presented. Is that correct?
Yeah, look, a hospital in the home activity is funded under the admitted patient telehealth events. So that's public services provided to an admitted patient who just happens to be located in their home.
So not hospital in the home, but just a consultation.
Oh, okay.
Follow-up consultation with one of your diabetic patients that you might have done in a general practice or at a hospital in a rural location, but you can now choose to go directly into the home and get the same funding element at the provider end. Is that what I'm thinking I'm hearing?
So it's probably the PEXA portal. So if you straight into the home, does that qualify some?
Sure, for an outpatient appointment. So instead of coming into the hospital to have your outpatient appointment, or instead of driving to your local community facility to have an outpatient appointment, you stay in your home and the specialist stays at, say, the Royal Brisbane, for instance, and you have your outpatient appointment. And the only difference between a face-to-face appointment and that appointment is the modality of communication, and that's video conference. So I can't see why that can't be, if it's public activity, then funded under the outpatient funding model. As long as the appointment has an appointment booked and it meets all the other scope requirements.
Another one.
Yeah, sure.
For the road. It's really confusing, isn't it? I mean, just talking to GPs
Yeah.
who are trying to catch up and see what's available at their end, and they're looking at the changes in the hospital sector as well. I guess I'm going to be your new best friend, Stephanie. So,
Wonderful. That's good.
is there a place where you can get real-time information on what is available? Because I know I went to the Telehealth round table, which was run by Checker.
Yeah.
And there was a lot of conflicting information.
Sure.
Between the various looks.
Yeah.
Goggles looking from the private sector versus goggles looking from the public sector.
Yep. In terms of, is there any real-time information, a couple of key documents exist, and I've summarised them in a 5 pages, and that's on the trade display. But the key documents would be the funding model, the Queensland activity-based funding model guidelines for this year. They'd be the Tier 2 definitions compendium, so that gives you your definitions for all your outpatients. So is it in scope to start with? The monthly activity collection manual, and the healthcare purchasing intention. So we've got the activity-based funding model that gives us our localisation, and that's in the model every year. We pay both ends of a non-admitted patient telehealth consult, and we pay at the Tier 2 clinic rate. For the Q hours. And then on top of that, we have the healthcare purchasing intention, and that gives us, we've got a $5 million cap for that, and that gives us money to spend on $100 for store and forward, $100 for emergency, $200 for admitted, and $200 for any activity above the cap for non-admitted. That is funding that's allocated year on year. So the challenge will be to build that funding and to build support for those services into the activity-based funding model in the future. But yeah, there are a number of key documents available, but it's about finding the relevant sections in each of them. Anyway, I've summarised that in 5 pages.
And Steph, just one other clarification, the block-funded sites, so a lot of our rural sites are block-funded. You've only got 4 ABF-funded sites.
Yep.
So the recipient site there, the Tier 2 dollars don't come to the block-funded
Yep.
sites. That's correct.
Yeah, that's correct. But the healthcare purchasing intention applies to ABF and non-ABF sites. So that's a bit, but I mean, really, you're not eligible because of the fact that you're still the small recipient site. The healthcare purchasing intention, although it's applicable to ABF and non-ABF, is for medical specialists only. for your emergency. So you wouldn't be getting those at your small sites, would you? What else is there? The non-admitted is still allocated. So activity above the baseline public is still out. $200 is still allocated to ABF and non-ABF sites.
So do you keep, sorry, from a reporting process, do you keep that data to go out to the HHSs at all, or can you report on that?
Sure. Now, the funding, the healthcare purchasing intention is managed by the purchasing team in finance. So my role, or the telehealth support unit's role in that, is to gather the monthly activity collection data and send it to the healthcare purchasing team. And then they do the calculation to work out what will be funded and what won't be. And the reason why they manage that is because they distribute the dollars for starters. And also we've got a $5 million cap. So if we expend that $5 million cap, then the money is not just allocated in first in, first dressed. It's allocated on a pro rata basis, and that's up to purchasing. The information about how much funding is allocated as part of that purchasing intention is supposed to go to the CFO in the first instance, rather than me sending it out to everybody. But what I do provide the telehealth coordinators, and can do if you ask me, is an estimate. So I think that's fair and reasonable to look at the scope for the healthcare purchasing intention, and then to look at our actual data and based on the scope and based on the data which everybody has available to them, I can estimate how much the allocation would be in the event that the cap is not expended. Yeah. Yes.
Will we be notified when we're reaching that 5 mil cap? It's just obviously depending on everyone's activity across the state.
Yep.
Because from a HHS perspective, obviously there's when it's happening.
Yeah. Sure.
Just needing to know if we're close to that 5 mil cap would be really good for us to say, probably to have those conversations with some of the key
Yes.
people throughout
Yep.
HHS, because I think sometimes they forget there's a 5 mil cap.
Yep. Yeah, sure. No, that's no problem. I'll talk to purchasing about that. I talk to purchasing quite regularly, so I'm sure that if I've just come back from maternity leave, and I do know the cap was exceeded last financial year, and I'm sure that if we were to exceed the cap or get close to exceeding the cap this year, they'd let me know. But I haven't been around in an event where that actually occurs. But yeah, I talk to purchasing weekly, so. Yeah, yeah, that's no problem. Yeah.
We don't know what every other HHS is doing, so we don't know where that dollar is up to.
Sure, I completely agree. Yep. Yep.
If we all got to our 20% stretch, that's a lot of money.
Yes.
Not that everybody will do that, but I'm just saying that that's a lot of.
Yeah. The 20% KPI?
Do you think that's something that is going to be ongoing?
Well, I think there's a lot of room. There's still a lot of room to move. A lot of room for growth, I should say, for telehealth activity. I think the other day I was working out that we did where telehealth activity represents non-admitted patient telehealth service events represents 0.6% of all outpatient services delivered by Queensland Health. Now, I recognise that some services aren't amenable to telehealth, and that it's not always clinically appropriate. But I do think that there's still room for growth. But having said that, the KPIs go out for consultation each financial year. So, yeah, we'll see. But if you have feedback on them, they're not working or they are working, then let us know.